care. All right. Now, looking at some of the complications of MI, that was just sort of a brief overview. These are what we're going to look at. And we'll spend the most time on the dysrhythmias because it's the most common, so that's what we will expect you to kind of understand. And then we will spend a little time on cardiac tamponade, rupture of the myocardial wall, cardiogenic shock. We won't spend a lot of time on those, or the ventricular rupture, or the ventricular aneurysm and sudden death. We're not going to spend a whole lot of time on that. We're going to talk about the ones we're going to see the most, okay? So the dysrhythmias, and I'm not going to be teaching you these rhythms because you've already had them, so I'm just going to skim over it real quick. But the most common complication is dysrhythmias in MI patients. 80% of them have dysrhythmias, so yes, that's what we're going to look at. But dysrhythmias are also what take people out before they even reach the hospital. Okay, so that's one of those reasons why it's important to get people, if they're having chest pain, to the hospital. Good luck trying to make your family and friends understand that concept. Atrial fib, you know, that's where the heart rate, the atria is fibrillating. You have a whole bunch of P waves. You really can't distinguish. It's like they're buried in there. It's wiggly squiggly, and the R to R is irregular. So here's all these little P's bumping in here, and then you see R to R, very irregular. That's the classic hallmark thing of atrial fib. And you'll remember on atrial fib that we're going to give them oxygen, possibly anticoagulants if they have just, if this is a new onset. If it's been there for a while, they may have clotty blood sitting in there, so we don't want to start stirring that up. So there's a lot of tests they'll perform and history and everything to know if it's new or not. They may do a cardioversion if it is new. If they can't get medications to straighten it out. Okay. No, amiodarone is going to be our drug of choice for just about everything, it seems. Premature PVCs, ventricular contractions. This is where we're having PVCs that come in too early, and these are not good things to have. They are the harbinger of bad things, so that's why we want to know. A lot of deaths are caused by it. And the foci, if they're unifocal or multifocal, means a lot to us. Here is a PVC here, and a PVC here. So these are multifocal. They're coming from different places, which means if they're all look alike, they are coming from one place, which means one area is irritable. But if they're looking all cattywampus and looking different, it means several areas are irritable. So we want to that gives us a little more cause for a little more scare. So we'll want to give medication for these as well. Now, ventricular tachycardia is when there's repetitive firing, and it can get up to like 250 beats. It's hard to know what's coming on, but your heart can't stand that for very long. And so we want to give medication, get them, if they're having chest pain, give them medicated and what have you. So I think I've got a picture of it. Here you go. Look, it looks quite angry, doesn't it? Okay. Now, you can have a patient that is stable, but they're not going to be stable for very long, I'll just tell you. So they'll be real quickly, they'll go into a worse dysrhythmia and check right out on you. But they can have a pulse initially, and certainly, we won't be doing CPR on them, but we might have them cough, try to get them to do cough CPR, if you want to call it that. And but if they're pulseless, hey, we're going straight into defibrillation and CPR. Okay, ventricular fib. Again, that's where we've got everything. It's just very chaotic. The ventricles are just bizarre, and this is going to take you straight to death. So we're going to be doing CPR. We're going to call a code and get the cart and be doing CPR and defibrillate immediately as soon as a cart's available. Certainly epinephrine or adrenaline is what we're going to give. I've got lidocaine in here, but we don't use lidocaine anymore. We usually do the amiodarone and some other medications. So you can drop out the lidocaine. Lidocaine caused a lot of problems and blocks and toxicity, so we don't really use it much anymore. Okay, so that talked about the dysrhythmias that you're going to encounter, and I didn't go into the blocks and all that are going to cause you to need a pacemaker. I think Mr. Holloway's going to do a lecture on pacemakers, so that'll be coming probably either next week or the week after. I think it's in our last cardiac session. So now we're going to talk about some of those other things that caused some problems for these MI patients. Okay? And the cardiac tamponade was the next thing, and this is just showing you what it looks like. That pericardial sac that's around the heart that has a little bit of fluid in it, and that's what happens is, for whatever reason, and sometimes it's because of the MI itself has caused an inflammation, and so fluid will kind of gather in this pericardial sac. So that it's like a pericardial effusion that occurs between that parietal and the visceral layers, and it gets full of fluid. And it doesn't take a whole lot of fluid. It can only be like 30 to 50 mLs of fluid. So it can cause a cardiac tamponade. Because remember, any pressure out here, you can see it's pressing on the heart. Okay, and if you get like 100 or 200 mLs of fluid in that, I have seen that happen. I've seen it happen even a little more than that. Believe it or not, you'd think, well, that can't happen. But that pressure exerted on this heart, there's no room for any filling, and so if there's nothing in there to be filled, there's nothing being pumped out, so our cardiac output is knocked way out, and this can kill the patient. So we want to see what kind of signs and symptoms we're going to get, and as you well might expect, see that tamponade restricts the ventricular filling, so the cardiac output drops, and an acute one can start, like I said, with 20, 30, 50 mLs, but it can even have more accumulation. And what we remember in your 102 classes, you had pulsus paradoxus, and you thought, oh, I'm never going to need that again. Well, now here you go. You got to pull it out, because of what you see is large decrease in the systolic blood pressure when the patient breathes. Now that makes sense when you have cardiac tamponade, because you've got lungs out here, and when they breathe, it even puts more pressure on this pericardial sac, so you see that the blood pressure is going to even drop more because there's less blood filling into the heart and pumping out to the body. So that's where you get that pulsus paradoxus. Also, we will see the central venous pressure will increase. And I know you don't know about the hemodynamic monitoring, but the pulmonary artery wedge pressure and the left artery pressures are all going to be, arterial pressures are all going to be increased as well. But the cool thing, it's not cool, but one of the characteristics that sets a cardiac tamponade out, where you can kind of recognize it, is we're always talking about jugular vein distension, and we usually see that with wet lungs. But in this scenario, we see jugular vein distension with dry lungs, with clear lungs. And that makes sense, doesn't it? Because the fluid collection is out around the heart. Okay? So that's one of those distinguishing features, is jugular vein distension with clear, dry lungs. And then we also will get distant, muffled heart sounds, because you've got all this fluid around the heart. And when you go to listen to the sounds of the mitral valve and all, you can't hear it as well because it's occluded because of all these things. So distant, muffled sounds, decreased cardiac output. On X-ray, the heart will look enlarged because the mediastinum will look enlarged because of all this fluid around the heart. So those are kind of the signs and symptoms. Also, you may get a decreased amplitude on the EKG. Okay? So these patients are placed in critical care. They do hemodynamic monitoring on them, which we'll be talking about a little bit later. They're going to manage their cardiac output and get x-rays and what have you. And they're going to prepare to do a pericardial centesis. You know, like a thoracentesis where you go in and they pull fluid out. Well, we go into the pericardial sac and pull this fluid out as well. And afterwards, and they'll send it off for testing and everything. But afterwards, we're going to be watching them to see if they re-tamponade. They may develop one again. They're certainly at a higher potential to do that. And what would be the signs and symptoms that they had done that? Exactly. We're going to be looking again for the JVD with clear lungs, the muffled heart sounds, decreased cardiac output, widened mediastinum. The heart looks widened on chest x-ray. Oh, are so good. Okay. That's all I'm going to say about the cardiac tamponade. Okay? So now we are going to take just a half a second break. Hold on. Okay, so looking at myocardial rupture, it's just that tear or break in the ventricle, and there is no coming back from that, so that is fatal. So that's all we have to say about it. Aneurysm, y'all know what an aneurysm is, where the wall becomes thinned out and bulging like. So a lot of times these can have emboli in them, and we're probably just going to have to deal with this, and they may do some surgeries that can repair or fix this, but it won't be in our scope of practice until we just do the care of whatever the patient has done. Now, some inflammatory conditions. We've got the pericarditis, and this is where the patient, you can see, they're going to have, during your assessment, the precordial pain. So that's in the front of the chest, radiates down the left side of the neck, shoulder, and back, and it's usually aggravated by breathing, particularly inspiration. So coughing and swallowing and all that is kind of difficult for them. Pain is usually worse when they are laying down, and it's very often relieved by sitting up and leaning forward. So that's what we'll have the patient do. We'll have them like lean over the bedside table like a tripod, you know. So that works for me. Sometimes you'll also hear a pericardial friction rub. It's kind of a scratchy, high-pitched sound on auscultation, and it's kind of like, I hope you'll be able to hear this. Kind of like hair rubbing together, and it's produced by the rubbing of the inflamed pericardial layers, okay? These clients very often will have fever and chills and have fatigue and malaise, an elevated white count, all because we've got inflammation going on, okay? EKG changes, signs of right-sided heart failure in patients that have chronic constrictive pericarditis. So we want to, our plan of action is going to be assess the nature of their pain, position them in side-lying or high Fowlers, or in an upright position with them leaning forward, like we said, giving them analgesics, non-steroidal anti-inflammatory drugs, or steroids as we want to watch for that, because we want to avoid, hold on, sorry about that. There's also, we want to avoid like aspirin and anticoagulants because they increase the risk of tamponade. So that would be we would give anti-inflammatories, but the NSAIDs, but not the aspirins. Okay. And here's a little picture, and this is what we would use for the cardiac tamponades, or just for pericarditis to get a specimen. But for the cardiac tamponade, you see here's the fluid, here's the heart, and then out in the pericardial sac there's this collection of fluid. So that's where we go in with a large, I say we, the doctor up under the xiphoid process and try to pull that fluid out. Okay? Sudden death sort of speaks for itself. Unexpected from cardiac causes, disrupts the cardiac cycle, certainly. Mostly these are caused by ventricular arrhythmias. Occurs less commonly as a result of primary left ventricle outflow obstruction. But anyway, here that's the big fact, is that it accounts for half of the deaths from cardiovascular causes. The sudden death usually within an hour of onset of symptoms. It's kind of rough stuff. So what we're doing, certainly while all this is going on, is we're doing some monitoring, because that's the biggest deal, is that we're going to see dysrhythmias. We're looking for those cardiac markers, the EKG, Holter monitor, stress test, electrophysiology tests, big departments around in Huntsville. And also, some of these patients may be candidates for implantable cardioverter or ICDs. And I know you've probably run across a few patients that have these. And when they sometimes know when it's going to shock, and they put these in because these patients are high risk for dysrhythmias, we need to tell them to sit down, maybe even lay down, because we don't want them like flaking out. So that's what we would do for them. And you can read in Iggy a little bit about them. And I think we're going to let this be the end of part 1, and then we will do part 2. Thanks.